Hi, good afternoon, everyone. My name is Ray. I am one of the alumni leaders and former presidents of National APAMSA and a cardiology fellow at Yale. I am very excited to welcome you to National APAMSA's workshop on EKG and telemetry reading. This is the most highly requested topic among APAMSA students this year and last year. Having these interpretive skills are indispensable because it's not just an academic exercise. Throughout your rotations, people are going to hand you EKGs and telemetry strips, including during your intern year, and ask, what is this? What do we do? And your interpretation will directly alter patient care. I strongly believe that EKG reading is a skill within everyone's reach. So I'm grateful to my friends for almost a decade now, Doctors Frank Qian and Alex Choy, for putting together this workshop, especially for you. I'll hand it over to our National Board student leaders, Elise and Tori, to orient you to today's format.
Thank you, Dr. Hu, for such amazing opening remarks, and welcome everyone to our EKG workshop for 2024. This session today is going to be hosted by our two alumni cardiology fellows, Dr. Alex Choy and Dr. Frank Qian. Today's session will be split into two parts. First part will be going over the systematic approach to reading EKGs. We'll have a 5-minute intermission, and then we'll go into part two with the practical guide to telemetry, tips and tricks for the wards, and interactive practice EKG cases. Please look at your chat box below while one presenting fellow speaks. We welcome you to ask questions, as the non-presenting speaker will answer your questions in the chat box, and we also welcome audience participation as well. So if you are an audience member and would like to answer a question from your peer, please announce your name, school, and year of training. Please tell us how we can improve next year. This is our first ever EKG workshop as an extension of our APAMSA Bootcamp Series. You can find the QR code here and then the link, and we'll also be posting the link in the Zoom chat box as the session goes on. And again, without further ado, I'm going to go ahead and pass it off to our first speaker today, Dr. Frank Qian, who's going to introduce a little bit about himself and then go into our first part of the workshop.
All right, so thanks, Alice, and thanks, Ray, for that very kind introduction. Let me just share my slides. Sorry. Can you see my slides okay?
Yes.
All right, very good. So thanks everyone for taking your Saturday to come join us for this boot camp, and I even saw someone was joining from Pakistan at 2 a.m. So hopefully this will be helpful and you'll learn something from this. So a little background about myself. So I grew up in Nashville, Tennessee. I did my medical school at University of Chicago. I also did an MPH. So those who are considering that degree, I'm happy to chat offline about my experience with that. And then I came out to Boston afterwards to do my residency, and I stayed here for my cardiology fellowship. And then a little bit outside of work. So I have a fiance who's working in law, and then we have a 2-year-old Bernie Doodle who's pictured up here. We're spending some time at the beach, and in my spare time I like to go swimming, hiking, and cook Chinese food. So my talk will be kind of going through how to systematically evaluate EKGs, and I think it's just helpful to have some basic understanding of how EKG is performed. So these are kind of the standard EKG placements. In terms of leads, you have usually 4 limb leads, and from those, when you kind of sum up the vectors in different ways, you get the kind of 6 limb leads on a standard 12 lead EKG. And then there's also these precordial leads. These are the placements that are considered standard, and obviously you don't have to memorize exactly the anatomical locations, but I think just intuitively thinking about them in terms of anatomical locations, you can sort of get a sense of how the EKG should look in terms of V1 is sort of towards the right side of the heart, so V2 is sort of towards the left side of the heart, and V3 is sort of towards the right side of the heart. So V1 is sort of towards the right side of the heart, so V4 is sort of towards the left side of the heart, and V5 is sort of towards the right side of the heart, so V6 is sort of towards the right side of the heart, you're capturing more of the right-sided forces, and then as you go more leftwards, you're getting more and more of the apical forces of especially the left ventricle. And we'll discuss more about how we can kind of tell different pathologies based on some of these findings. And most of you probably already know this, but in terms of how we look at EKG forces, so positive force or upward deflection on the EKG means the electrical force is heading towards that lead, and then negative deflection, the electrical forces are heading away from that lead. And then just to go through some EKG nomenclature to make sure we're all on the same page. So this is a standard EKG, and these are kind of the usual waveforms that I'll kind of break down systematically as we go through this talk. So usually you'll start with a P wave. This, as you can see from the diagram here, this represents atrial depolarization. And then follow that is the PR segment. This is when, after the atria have depolarized and the electrical forces are kind of making their way down to the AV node. And then next you have the QRS. And, some of you may ask, so what's going on with the atrial repolarization? Well, typically this is actually not, usually seen on an EKG. It's kind of hidden in the QRS segment. What is the QRS segment? It's essentially what is referred to as the ventricular depolarization. And the reason you have this kind of initial downward force is when the ventricles depolarize, usually you actually have the first part that gets depolarized is called the interventricular septum. So the wall between the left ventricle and the right ventricle. And so there's actually an initial force away from the rest of the ventricle. So hence why it's an initial negative deflection. And then afterwards, you have the conduction down the rest of the conduction system, the His-Purkinje system into the bundles, and then throughout the rest of the left and right ventricle. And this is sort of represented by the entire QRS segment. And then after that, you have this. After that, you have essentially an isoelectric point, which is the beginning of the ST segment. And many of you probably know this because this is how we typically diagnose if someone is having either ST elevation myocardial infarction or non-ST elevation myocardial infarction, and we'll get into that as we go along. And then finally, the last part of the EKG is the T wave. This represents ventricular repolarization. And one characteristic I'll point out about the T wave is usually you have this kind of slow upward deflection and then a more rapid downward deflection. Sometimes on an EKG, especially in certain clinical situations, you also have this additional waveform called the U wave. And in the sake of time, I won't dwell too much on this particular waveform, but just know that it usually follows the T wave, and it's actually, sometimes it can get confused for the next P wave, but this is actually called a U wave. And kind of the most common situations we might see this particular waveform is if someone is having severe hypokalemia as well as severe bradycardia. One other thing I'll mention about the EKG kind of, sort of how we measure time on an EKG. So each of the small boxes represents 40 milliseconds or 0.04 seconds. And then each of the big boxes represents 200 milliseconds or 0.2 seconds. And typically a standard sort of 12 lead EKG is taken over a 10-second period of time. And so, after discussing that, I think the first part, when we started medical training is we're often asked, what is the rate for a particular EKG that we're looking at? And there's three different ways that, we can typically determine this. One of them, and this is why I mentioned sort of, what the big and little boxes are. So one of them is called the large square method. And for both the first and second method, it's important to keep in mind that you can only determine rate this way for regular rhythms. So if the rhythm is completely irregular, we can't use either of these methods. But if, let's say it is, then typically how we get, beats per minute, which is the, usual way we talk about rate, is you can take 300 and divide by the number of large boxes between each of the RR interval. And that would be, for example, here, there's about, 4 big boxes or so between the intervals. So this, EKG, you would say it would be 300 divided by 4, which is about 75 beats per minute. The second way, and this is actually useful in particular for rhythms that are more, faster, where you might not get exactly, one big box or exactly, a whole number of big boxes. This way you can take what's called, you can take 1500 divided by the number of small squares. And mathematically this makes sense because each big square is about 5 small boxes. And hence if you, take 300 multiplied by 5, you're kind of getting, where this 1500 is coming from. So this is another way you can determine it, particularly for, fast rhythms or rhythms where the boxes don't line up as nicely. The third method you can use if the rhythm is irregular, and one of the common situations you might use for this is if someone was having atrial fibrillation. So many of you probably know atrial fibrillation, the rhythm is what we call irregularly irregular, meaning that you just can't accurately get a sense of the rate by looking at the number of boxes in between. But recall that each EKG, standard EKG strip is about 10 seconds in duration. So what we can do is count the number of R waves. Usually you'll have a rhythm strip kind of at the bottom. Usually it's either lead 2 or lead one of the B precordial leads, and then you just multiply by 6 because there's 60 seconds in a minute, and that's how you get your rate. And you can, I specifically mentioned this is for ventricular rate, but you can also use the same method for calculating atrial rates. And typically the nomenclature we use, bradycardia is less than 60 beats per minute. Normal, especially for what we consider for sinus, is 60 to 100 beats per minute, and then tachycardia is greater than 100 beats per minute. The next is determining axis. After determining rate, we can also tell a lot about the heart as well as various pathologies by looking at the axis. And typically in a healthy heart, the axis is somewhere between -30 degrees and 90 degrees. And this is sort of laid out in a vector plot. So I'll orient you a little bit. So lead 1 is heading from left to right. And then the inferior leads 2, 3 AVFs is sort of heading towards the inferior or, towards the ventricles. And AVR in particular is sort of, I think it's kind of mislabeled here, but AVR is actually heading sort of in the, towards the northwest part of the of the heart. And so you can think about, in a typical, healthy heart, conduction should be occurring kind of, from the high right atrium where the sinus node is, and down and towards the left. So this is the right, even though it's pictorially on the left, but you're kind of conducting from the SA node through the atria and then down the AV node and then through to the ventricles that way. And that's why you can kind of intuitively think about lead 1 is kind of from your right arm to your left arm, so it should be in general positive in a normal heart. And then the inferior leads should usually be positive as well because the electrical signal is heading towards the inferior leads. And then AVR in a healthy heart will generally be negative because you can think about if there's a positive deflection, this is heading from the ventricle towards the atria, which obviously isn't how normal conduction works. And to kind of summarize it in a table, this is actually what I still use to determine axis, although, there are obviously more sophisticated ways of doing it. But the standard way of determining a normal axis is if it's positive in lead 1, positive in lead 3 or ABF, and then also positive in lead 2. You can get a what we call a physiological left axis deviation from 0 to negative 30 degrees if you have positive in lead 1, negative in lead 3 or ABF, and then kind of isoelectric in lead 2. And if you just think about that intuitively, so it's heading towards this direction, but it's sort of because it's negative in ABF and 3. This is sort of heading away from that direction, but still, because lead 2 is in the positive direction, you're kind of in this specific quadrant here. And then you have a pathological left axis deviation if it's negative in lead 2 and ABF, but positive in 1. And then it's sort of flipped for right axis deviation. And again, if you think about lead 1 in particular, if you're heading away from lead 1, in which case you'll get a negative deflection, then you're kind of in this quadrant over here. And then, presumably if all your other leads are still normal, then you're kind of heading towards the inferior part, so you're in this quadrant. And then the extreme axis, sometimes, we also say indeterminate axis, is heading kind of away from all of these leads, and typically we'll talk about specific situations when we can see this, but oftentimes we'll see this in ventricular tachycardia, because you can imagine ventricular tachycardia, the force of conduction is from the ventricles towards the rest of the heart. So a lot of times what you'll see is actually a positive deflection in AVR, but sort of overall your axis heading away from the rest of the heart, that you normally get. Next, I wanted to talk a little bit about how to determine rhythm. And, this is sort of the most kind of tricky part of reading EKGs. But some ways we can at least systematically get at that is, we talked a little bit about rate. So we can, talk about, is the rate slow, normal, or fast? The pattern of the QRS complexes, in which we can, the typical nomenclature we use, like, is this regular? Is it regularly irregular? And we'll talk about situations where we can see that. Or is it irregularly irregular? The most common of rhythm where we see this is atrial fibrillation. Is the QRS wide or narrow? And this will typically determine if a rhythm is coming from above the ventricles or from the ventricles. And then there's also sort of a more nuanced version where it can be wide but still coming from above the ventricles in a situation called aberrant conduction. And then the P waves, the one thing I came to appreciate as a cardiology fellow that I didn't really appreciate as much before is, you really want to see what the P waves are doing, because this will tell you exactly what the underlying atrial rhythm is. So there's several situations. Is it present or absent? Present meaning it's probably, there's conduction from the atria. Absent meaning there's probably, either a junctional rhythm or a ventricular rhythm. And then, how do the P waves look, as well as the rate. And then other things, relationship between the P waves and QRS complexes. So, typically when we first started learning EKGs, when we're taught sinus rhythm is, we think about a P wave before every QRS and a QRS after every P. And, a more kind of advanced way of thinking about this is the P and QRS are associated, meaning that there's, a one-to-one relationship between them, or sometimes a, 2-to-1 or 3-to-1 relationship. Or if they're intermittently associated, and we can talk about this in particular, you will see with various types of heart blocks, or are they completely disassociated? The other one is, it's very helpful in determining especially types of tachycardias. is looking at the onset or termination. So, is the tachycardia gradual or abrupt versus is it initiated by, some kind of premature atrial ventricular beat? And we'll talk about more kind of specific situations later on to kind of flesh this out a little bit. So, when you start EKGs, you actually, one helpful way is to read a lot of normal EKGs. So this is about as normal as you can get. So you can see that, the P waves are, and we'll talk specifically about how to determine if this is sinus, but it's upright in one, upright in the inferior leads. So this is sort of heading, you can recall, like heading from the high right atrium down towards the rest of the heart. And the axis here is also normal. So up in one, up in AVF, and up in two. And then, all the other things we'll get into, but overall, this is what you can see for a normal EKG. And so next, I'll kind of go into the section where I sort of break down the each of the components of the standard kind of EKG complex. And we'll start with the P wave. So the P wave, as you call, is represents atrial depolarization. And you may or may not know this is actually kind of a fused complex of the right atrium as well as the left atrium. And under normal circumstances, you'll see just one kind of smooth waveform, because the complexes are kind of overlapping. But the important thing to know in reality is the right atrium actually depolarizes slightly earlier than the left atrium. And in certain pathologies, you can actually see the P wave have, sort of a less of a smooth contour based on if there's, you can imagine things like left atrial enlargement or right atrial enlargement, you can actually get sort of a different appearing P wave. In general, it should be monophasic in lead 2, and that's, if you look back at this EKG, it's not the best example, but let's just say this is monophasic. So, it should be a very smooth contour. And normally it can be biphasic in lead V1, which you recall is the lead kind of overlying the right side of the heart, or sorry, the RV. So, typically the waveform will be biphasic. The normal P wave axis is between 0 and 75 degrees, and that's sort of what I was doing earlier with this EKG. So you can look at lead 1 and then the inferior leads, either 2, kind of pick what you want, but 2, 3 AVF. And it should usually be upright in all of these. And this is what you would consider kind of a normal sinus P wave. And typically it's inverted in AVR. And if you recall where AVR is, it's sort of heading away from the rest of the heart. So, logically speaking, sinus P wave should not be doing that. So typically you'll see a negative deflection AVR. The duration, it should be less than 120 milliseconds or 3 small boxes. And, if it's stretched out, it often means there can be some pathology with either, left atrial enlargement is often what can cause the P wave to get stretched out. So we'll take a look at some examples of various atrial rhythms. So this is an EKG showing sinus tachycardia. But again, you can apply some of those techniques I just talked about. So looking at the P wave, you can see upright in one, upright in the inferior leads. So, this is kind of coming from the right side of high right atrium and connecting down towards the rest of the heart. And you can see it's, very smooth contour. There's no kind of notches or, and the duration is clearly less than 120 milliseconds. Now, this is kind of a variation of that. So this is what we call an atrial tachycardia. And one of the ways you can tell this is probably not sinus is, you might be able to make out it's sort of isoelectric to, almost negative in 1. And then also there's an inverted P wave in 2. So this is not heading towards the inferior aspect of the heart. It's actually heading away from the inferior aspect. But probably coming from somewhere below the sinus node. And one other way you can tell is you can almost see like a positive deflection in the AVR, which you recall is, heading away from the rest of the heart. So this is probably coming from some focus outside of the sinus node and then conducting, to the rest of the atrium that way. So, that's why it's important to pay attention to, in particular, I would say leads 1, and the inferior leads to see, is this actually a sinus P wave, or is this some kind of what we call ectopic or, atrial P wave that's not sinus. So atrial flutter is another kind of atrial activity you can get. And as opposed to what we were looking at for sinus tachycardia or atrial tachycardia, and we'll hop back real quick. For sinus tachycardia in particular, you can see there's a very nice kind of isoelectric segment after the P wave before the QRS deflection. You don't really see this with atrial flutter, and this is because atrial flutter, the mechanism is there's this kind of continuous circuit, and the particular type of flutter we have here is something called typical flutter or counterclockwise flutter, where there's essentially this continuous electrical activity, going on inside the right atrium, and you never see kind of that isoelectric form, but you see this kind of continuous, sawtooth appearing pattern. So it's important to recognize this because this type of atrial activity is obviously not some kind of normal atrial conduction. And the other thing to know about atrial flutter is usually the rate of the atria is about 250 to 300 beats per minute. And you can, in this situation, if you calculate out, this is kind of the beginning of one flutter wave to the next, it's about one big box. So this particular type of atrial flutter is about 300 beats per minute. And then you can see that, the ventricular rate is about a proportion of that. So about, half of that. So this is what we call a flutter with 2-to-1 AV block. And you can see that the ventricular rate, if you calculate it out, is about 150 beats per minute. And this is another commonly, encountered rhythm that you'll see on the wards, atrial fibrillation. At first glance, you might, some of the waveforms you might say, oh, that kind of looks like flutter. But if you especially look at the inferior leads, the morphology is very different from of the the atrial activity is very different. So this is, we can say this is something called coarse atrial fibrillation, where you kind of see, it almost looks like there's organized atrial activity, but as you can see, it's very irregular. Actually, what we call irregularly irregular. And then if you look at, kind of the overall rhythm strip, you just don't see any organized atrial activity. All right, so moving on, we'll talk about the PR segment. So this is sort of, you measure from the beginning of the P wave to the beginning of the R QRS complex. And typically, this sort of represents from the beginning of atrial depolarization to the beginning of ventricular depolarization, sort of the electrical signal is making its way down into the AV node, or and through the AV node. So the normal PR segment is between 120 and 200 milliseconds. And if it's greater than 200 milliseconds, we say there's first degree heart block, or technically the correct term is first degree AV delay, because you actually aren't seeing any blocked conduction. And then and you can, this is one example here. You can, if you count from the beginning of this P wave here to the beginning of the R wave here, you can see that, it's clearly more than one big box, so, greater than 200 milliseconds. There's also a situation where you can have a shortened PR interval, And many of you probably have heard of this phenomenon. This is called a delta wave. So this is typically when there's an accessory pathway present, so that normal conduction should occur down the AV node, but in this particular situation, there's another kind of bypass track through which the atrial electrical signal can get directly into the ventricle, and hence why you don't have that nice kind of flat isoelectric point after the P wave. You have this sort of slurred upstroke. And one particular syndrome that's associated with this is called Wolff-Parkinson-White, and we might have an example of that later where we kind of see this phenomenon. So this is called this is called a delta wave, or in kind of formal cardiology terms, we refer to this as an accessory pathway. And one particular pathology you can often see with the PR segment is something called PR depression. And in particular, this condition, you often see this with pericarditis. So what you'll see is, you might ask, oh, where do you start measuring that? Well, so you have, after the T wave, you have this TP segment, and typically the PR segment will be depressed below that. And the reason I say that is because a lot of times with pericarditis, you'll have concomitant ST elevation, which you can see here. Now, this is not a STEMI because you can see that there's a very diffuse ST segment elevation. So you have it in the inferior leads, but you also have it in the lateral leads. And in general, you wouldn't be seeing that in acute coronary syndrome or STEMI. You would see kind of more localized to a particular coronary anatomy. But you can see very clearly there's PR depression, which is one of the hallmarks of pericarditis. And then moving on, another common pathology you'll see that's in a way related to the PR segment is heart block. So I already talked a little bit about first degree AV block or AV delay. It's just when the PR segment is greater than 200 milliseconds. In general, there's nothing you need to do for this. It's a totally benign condition. There's also second degree AV block, and there's several different types that I'll go over that are commonly encountered. So we break this down into Mobitz type 1 and type 2. Mobitz type 1 is often also called Wenckebach. So what you have here is, essentially a progressive prolongation of the PR interval, and then right before the longest, right after the longest PR prolongation, you'll have a drop beat. And this is in general considered to be a benign rhythm because the block is occurring at the level of the AV node. Whereas Mobitz type 2, this is more of a pathological condition. And what you'll have here is a fixed PR interval and then just intermittent non-conductive P waves. And the reason this is more pathological type of block is the block is occurring below the level of the AV node, sort of in the what we call infranode or Hessian block. And this will, the reason this is more dangerous is a lot of times this will progress into complete heart block, whereas Wenckebach in general is not, not problematic as long as the patient is not too symptomatic from it. There's also a variation of both of these called 2-to-1 AV block, and this is where you basically have, a normal kind of a normal QRS complex, and then followed by a P wave with a drop beat. And this is, you're basically dropping after every second beat. So, and the reason, this is more tricky is because you can't really determine if this is Mobitz 1 or 2. And the reason being, for Mobitz 1, you have to see if the PR is prolonging over time. And if it's dropping with every other beat, you just can't see that. So that's why, 2-to-1 AV block, in general, that's what it's called. You can't say whether it's Mobitz 1 or 2 definitively. Now, third degree AV block is, sort of the most dangerous form. This is also complete heart block. And in this particular, condition, there's something called AV dissociation, meaning that the atria are firing and the ventricle is firing, but they're just not talking to each other. There's no correlation between the atrial conduction and the ventricular conduction. And one particular thing to keep in mind is that to call it kind of third-degree heart block or complete heart block, in general, the atrial rate will have to be faster than the ventricular rate. And in this particular situation, the ventricular rate can either be a junctional escape, meaning it's occurring somewhere near the AV node, or ventricular escape, so occurring somewhere from the ventricles. And so this is, we'll go through a couple of examples. So this is an EKG of someone with Wenke block or Mobitz type 1, second-degree AV block. So you can see that, this is a dropped beat, and then after that, you have this PR segment, and you can see as it goes along, it kind of eventually prolongs until it drops again. And then you see that pattern pick up again, PR is prolonging, and then eventually it drops. So this is a classic, Mobitz type 2, Mobitz type 1 or Wenke block. This is a rhythm strip of complete heart block. And you can see that, the reason you can see that it's complete heart block is if you march out the atrial, rates, you can see that, P wave, P wave, P wave, P wave, and then there's just no association between P wave and QRS. And another way you can see that is, this P wave, it might look like it's associated, but you can see that it's, the PR segment is extremely short. So, in general, this is unlikely to be actually conducting through. And the atrial rate is remaining fixed. You can, if you march these out, it's going at about, 75 beats per minute. And then the QRS complexes, if you march it out, you can see the interval is very fixed. There's no variation at all. So this is a situation of complete heart block. And you can also say that this is probably a junctional escape rhythm because of the morphology of the QRS. So it's pretty narrow. If you have a ventricular escape rhythm, it'll typically, the QRS will be wide because, the ventricles, if you're conducting kind of cell to cell, the rate of conduction will be much slower. So moving on to QRS, and then I'll first discuss a little bit about Q waves. So Q waves represent sort of normal left to right depolarization of the interventricular septum, and that's sort of what I was talking about earlier. You'll have this initial kind of negative deflection because the septum is the first to depolarize, and it's sort of going away from the rest of the ventricle, hence why the negative deflection. So it's actually normal to have Q waves in most severe leads, with the exception of V1 through V3. This is, this is what we call kind of the septal leads. And in general, for these leads, it's pathological to have a Q wave in these. Pathological Q waves are typically from prior myocardial infarctions. And you can sort of think about that in the way of, you essentially just don't have myocardium here to conduct electrical signal. It's all just scarred over. So the electrical signal is kind of headed away from that part of the myocardium. To define something as a pathological Q wave, it needs to have a certain width, so greater than 1 small box, and then greater than 2 small boxes deep. Or if you have, for example, very low voltage, it needs to be at least 25% of the QRS complex. And this is just some examples of pathological Q waves. So this particular EKG is from someone who's probably had an inferior MI. You can see that there's this, pretty deep Q wave in leads 2, 3 AVF, which are the inferior leads. This is obviously more than 2 small boxes, but you can also see that it's, probably at least 25% of the QRS complex. You can also see Q waves in sort of an acute MI as well. So, this is probably from an old MI, but on the QMI, you can also see that because, you see here, it looks like there's actually ST elevations in the precordial leads. And then you have these kind of very deep Q waves that are already formed. and as you call, leads V1 through V3, you should never have a Q wave. So these are by definition pathological, but they're also, very deep and kind of wide as well. So QRS complex, this is sort of represents ventricular depolarization. It should be very narrow because, normal ventricular conduction occurs through the His-Purkinje system, which is in general very fast. So the normal QRS width should be between 70 to 100 milliseconds. So about, a little bit more than 2 small boxes or so. You also have, narrow complexes in general are considered to be supraventricular in origin. And you can also have wide complexes, or broad complexes where the QRS is greater than 100 milliseconds. And this is either, ventricular in origin, or this is sometimes called aberrant conduction of supraventricular complexes. So, and we'll discuss this in more detail with specific examples, but this can occur either in the setting of a bundle branch block, hyperkalemia, or if you recall from pharmacology, your kind of class 1C agents, or class 1 agents in general, they tend to widen out the QRS. So you can actually have a wide QRS that's supraventricular, but if, under these circumstances, you can get, sort of what we call aberrant conduction. And in order to diagnose a bundle branch block or a ventricular rhythm, the QRS really needs to be more than 120 milliseconds or 3 small boxes. So talking about the bundle branch blocks, so, left bundle branch block, the typical nomenclature is William. So you will have a kind of a very wide S wave, or sorry, very deep S wave in lead V1, and sort of, so that's the W here. And then the M is, lead V6, you have this very tall R wave. You'll recall that, typically in the lateral leads, you'll have a little bit of initial Q wave, because this is sort of representing interventricular conduction. So you really lose that in a left bundle branch block because of the way the electrical signal is being conducted. In this situation, it's sort of more direct myocyte to myocyte conduction, so it's very slow. And then you also don't get the septal forces that you normally see. And you will also typically see kind of T wave inversions. There's not a particularly good EKG, but here, this is sort of, you can see sort of a T wave that's inverted. This is actually part of the left bundle. So, don't be alarmed that, typically when we think of T wave inversions, we might think of ischemia, but this is just part of the normal left bundle. And a specific type of left bundle pattern that you'll see is with pacemakers. So this is a paced rhythm, and you can tell that because there's these little pacing spikes. And typically, most people will have what we call an RV pacer. So you'll typically get a left bundle pattern with that. And this is because, if you think intuitively, the RV pacing is activating the right ventricle first and then the left ventricle. So, when it gets to the left ventricle, it's sort of conducting from myocyte to myocyte. And that's why you have this very wide kind of conduction pattern. And, because the right side is getting activated first, the left side later, that's why you have a left bundle pattern. And then the right bundle pattern is, in a way kind of flipped from the left bundle. So the typical, mnemonic for this is called Morrow. And this is because you get something called an RSR prime complex. So, sort of the rabbit ears in V1. This is your M. And then you get a sort of a almost, it almost looks like a normal QRS in V6, but this is sort of your W. Again, the QRS duration has to be greater than 120 milliseconds. You have this, very tall kind of RSR prime pattern, and then a sort of very wide slurred S wave in particularly the lateral leads. And you also sometimes get these, T wave inversions, particularly in the, in the first 3 precordial leads when you have the kind of RSR prime pattern. And so, kind of putting that all together, this will be helpful when to recognize like a ventricular tachycardia or, any kind of ventricular rhythm. So you can see that, you might start off by saying this is a wide complex tachycardia because the QRS, if you look in particularly like lead 1, it's certainly more than 3 small boxes. It's probably closer to like 5 or 6 small boxes. So, clearly this is not supraventricular because of how wide it is. And one other, for the sake of time, I won't go through all the ways of determining how this is ventricular tachycardia. But one way you may recall from, our talk of how to determine axis is that, look at what the axis is. So negative in 1, negative in AVF. So that means, and actually positive AVR. That means that this is heading away from the rest of the heart under normal conduction and actually towards kind of a northwest axis. So in general, this is not consistent with, any kind of supraventricular rhythm. This has to be ventricular because you can imagine this is essentially the heart conducting from below back up to the atria, and hence why you have this, what we call an extreme axis deviation. So moving on, we'll talk about the ST segment. So this is a flat isoelectric point between the end of the S wave, also called the J point, in the beginning of the T wave. And this really represents, the interval between ventricular depolarization and repolarization. And in general, we worry about myocardial ischemia or infarction when there's sort of a deviation from this isoelectric point, either elevation or depression, depending on if you had an ST elevation myocardial infarction or ST or non-ST elevation myocardial infarction. And I think this is probably one of the most helpful things you can learn, especially as a medical student, but also early on in residency, is sort of localizing where the ischemia might be. And this is kind of the classic territories. You can also think of these intuitively. So you recall where the lead. So looking at the precordial leads, for example, you recall where they're placed. So V1 is sort of the anterior aspect of, or sorry, V1 through V4 is sort of the anterior anteroseptal part of the heart. So typically this is supplied by the LAD. And then sort of the lateral way, leads V5, V6, or 1 AVL. This is sort of capturing, more towards the very left side of the heart. This is typically supplied by the left circumflex, or sometimes it can be a diagonal branch of the LAD. And then the inferior part of the heart, 2-3 AVF, is usually supplied by the RCA or the left circumflex, sort of depending on, you might have heard these terms like right dominant or left dominant. This will, sometimes help determine if this is RCA or left circumflex. And in general, some general rules of thumb. So, and we're specifically talking about ST elevations here. So if the ST elevation is greater than 3, a lead 3 than lead 2, usually this is RCA because, this could be RCA or left circumflex. If it's greater than in 2 than 3, then this is actually often consistent with the left circumflex STEMI. And then a couple of tips about especially RCA STEMIs, so inferior ST elevations, is you always want to think about if there could be RV involvement. And the way you get that is you get something called right-sided leads. So essentially you take, V4, 5, and 6, they usually kind of wrap around the left side, you just put them on the opposite side. The other situation you can sometimes get with, especially an inferior MI, is if you see a pattern where you have anterior or septal lead ST depressions. In this situation, you want to think about if there could actually be a posterior infarct. So this is when you might get posterior leads. And the way you get it is you basically take V4 through 6 and kind of put it on the patient's back. A couple of general situations you might see with abnormal ST segments that are actually benign. So this is a pattern called early repolarization. And if you recall, this kind of point here right after the S wave is called the J point. And you can see, there is some ST elevation, but it's mostly at the J point. And specifically, if someone wasn't having symptoms and they just showed up with an EKG like this, it's extremely unlikely they're having an ST elevation MI. This is just, related to, a different kind of repolarization pattern. Another thing you can see is, that you can see ST segment abnormalities is something, called left ventricular hypertrophy. And for the sake of time, I won't go through the criteria, but you can see that, you have these sort of very deep S waves, and then at the J point, again, there's some ST elevations. And particularly in the lateral leads, you can actually see ST depression and some, sort of a more biphasic T wave. And this is often also referred to as a strain pattern. So again, this is not, an ST elevation myocardial infarction or non-ST elevation myocardial infarction. This is probably most consistent with left ventricular hypertrophy. I'll try to speed up a little bit because I think we still have a lot to get through, but moving on, we'll talk a little bit about the T wave. So the T wave is, again, what we consider for, ventricular repolarization. So it should generally be upright in all the leads except AVR and V1. And again, this is depending on, we kind of talked about why it might be negative in AVR. And also in general, it's sort of biphasic or negative in V1. The amplitude, it should be, smaller than 5 little boxes in the limb leads, less than 10 little boxes in the precordial leads. And T waves are something else we can use to help us, diagnose if someone is having myocardial ischemia. In particular, if there's dynamic T waves changes. So, let's say someone had an EKG a month ago, all their T waves are upright, and now all of a sudden, in the inferior leads, they have T wave inversions. That would be consistent with potentially in the right context, a new myocardial ischemia or myocardial infarction. If it's fixed, this is often associated with a prior infarct, and you can kind of see it here. So one other thing just kind of review, you have these Q waves in leads V1 through 3, as well as V4 actually. So V1 through 3, you should never have Q waves. So this is pathological by definition. And then you also have these T wave inversions, which again, is consistent with a prior kind of anterior septal or anterior infarction. A couple of specific scenarios. You can have something called peak T waves, and you may recall earlier, the way I described T waves is that it should have this kind of slow upslope and then a rapid downslope. You lose this in something called peak T waves, where you have kind of more symmetric T waves. And many of you are probably very familiar with this condition. This is hyperkalemia. And the reason, just to kind of distinguish from the next EKG I'm going to show you, you can see it's very diffuse, right? So all the T waves have this kind of peak pattern. This is when someone is having hyperkalemia, and you'll want to treat them for that. So just to kind of contrast it with the previous EKG, this is something called hyperacute T waves. So again, you can see this very sort of peaked pattern, which you might say, oh, is this hyperkalemia again? But you can see that there's actually a very specific localization, in particular to the sort of anterior precordial leads, so V1 through V4. They also, again, have this kind of symmetric, similar up and down stroke. So this is actually something called hyperacute T waves, or, we'll usually see this as the first change, even before someone has an ST elevation, you'll have this kind of peaked or hyperacute T wave. And again, you don't see that anywhere else except kind of the anterior precordial leads. When you see this, especially in the right context, if someone was having chest pain, never want to ignore that. And then kind of moving on to the last segment, we'll talk about the QT segment. So this is from the start of the Q wave to the end of the T wave. The length is usually proportional to the heart rate, so shortens at faster heart rates and lengthens at slower heart rates. And this property is actually very useful if we want to treat someone, for example, with prolonged QT. One of the ways we'll treat them is either get them use drugs to accelerate their heart rate, so it shortens the QT interval, or sometimes we'll pace them at a faster heart rate if we can't get them there with drugs. And that way we can shorten the QT interval. Generally, because it has this property, you'll need to correct it for the heart rate. And on a standard 12-lead EKG, when you have a machine read, they'll often give you a QT, but also comes with a QTC, and this is sort of the QT corrected to a heart rate of 60 beats per minute. And these are kind of the cutoffs you just have to memorize. So like greater than 440 in men or 460 in women is considered prolonged. And one way you can, if you're just kind of eyeballing EKG, the way you can tell a QT is prolonged is a normal QT should be less than half of the preceding R interval. And if it's longer than that, it's considered prolonged. And again, this can be due to a variety of drugs and electrolyte disturbances. So this is just one EKG showing QT prolongation. You can see, if you measure from the beginning of the QRS to the end of the T wave here, this is definitely more than half of the RR interval, which you can see here. So this is a quite prolonged QT. And one of the reasons we worry about QT prolongation is something called torsades de point, or twisting about a point. And this is sort of a specific type of polymorphic VT associated with a prolonged QT interval. And a lot of times what you'll see, this is kind of a rhythm strip showing torsades, is you'll have this prolonged QT. You can see it's quite prolonged here. And then there will be an premature, either atrial, usually a ventricular complex, PVC, that, if you time it at exactly the right spot, so, you can see here, it's still okay, and then boom, the PVC just lands right on the T wave, and it sets off this torsades. And you can see this is, it has this pattern where it's, the QRS is very kind of chaotic and polymorphic, and then sort of grows in amplitude, shrinks down, grows in amplitude, shrinks down, sort of, twisting around a point. And specifically this phenomenon we call an R on T phenomenon, where you have a PVC that occurs right on the T wave. And in general, the reason we are concerned about this is, sometimes a short run, it'll normally, convert it back into a normal rhythm. But if it goes on for a period of time, it can degenerate into ventricular fibrillation. So this is a situation, you have prolonged QT and then PVC, and then it sort of sets out this run of torsades, and then it degenerates into VFib down here. All right, great. So apologies for running over a little bit, but that's sort of the end of my section, and I will turn it over to Alex before we discuss some EKG cases. So thanks.
Nice job, Frank. Just since it's a whirlwind of a talk, we'll give everyone like 2 minutes just to kind of grab a drink of water or something. All right. Can everyone see my screen?
Yes.
Okay, cool. All right. Thanks for joining us. Thanks for spending your evening or afternoon, depending on what coast you're on. Alex, I'm one of the third-year cardiology fellows at Mount Sinai Hospital. I'll be starting EP in 2 months or so. Here's my little biography. I was pretty involved in APAMSA as a medical student, and this is a picture of me and Dr. Who from last weekend, little APAMSA get-together. So just to get an idea of like where everyone's at, if we can pull up the first question on the Zoom poll. For the outline for the talk today, we'll be going over telemetry tips.
Dr. Choy,
yep.
We cannot see you advancing the slides, and I will launch the poll.
Oh, okay. How about now? You see outline Q1?
Yes, we can see that. Thank you.
Okay, cool. All right. So we'll go over telemetry trips, hemodynamic review, how to identify artifact, looking at some rhythm strips, and using data you didn't know you had. So in the poll, so it looks like about 80% of you have not heard of hemodynamic review or graphic trends. So a lot to go over today. Hopefully some of these tricks will be helpful when you start on the wards. So the issue with events and alarms, depending on how the telemetry is programmed, rhythm switches, for example, if patient goes between rate controlled AFib and they self-cardiovert into sinus rhythm, the machine's not going to put an alarm saying, oh, the patient's in sinus rhythm. So you'll have to kind of check manually. Oftentimes, especially on the medical floors, the alarms that you get are going to be non-rhythm related. So this is just an example of, an overabundance of alarms on the telemetry that just say, tachypnea, respiratory rate over 30, hypoxemia. So they're not always that helpful. So learning how to check hemodynamic trends is pretty important. It'll save you time when you pre-round. You'll get information faster, and you'll know more about what's going on with the patient. I'll put up 2 examples of 2 hospital systems of how to check. If you click review, it's safe to check wherever you go. I understand everyone's going to be working at different hospital systems, but there's usually some way to click something that's like graphic trends or hemodynamic review. So in this example, if you press patient data, click graphic trends, you'll get this nice plot, which is basically the patient's heart rate over time. And so this information allows you to kind of zone in or zoom into regions of interest that maybe something changed with the patient, or oftentimes alarms don't actually tell you this is when something happened. So this would be super helpful. This is just an example. Let me just put on laser pointer. This is an example of a patient who had cardiac surgery. They were being paced. So you notice that their heart rate is very flat. So they're at a fixed heart rate because of the pacemaker. Eventually it's turned off, and then actually the patient later goes into atrial fibrillation. So you see this kind of erratic, the heart rate measured over time changes very erratically. So that can clue you into someone being in, AFib. I highly recommend searching Joshua Cooper. He's an excellent teacher, medical educator. These 2 slides are actually from some of his talks on YouTube. But this is an example of that heart rate over time trend. So you can see over here, maybe the heart rate's in the 80s and all of a sudden jumps up to like in the 120s or so. Something's going on a little bit irregular, and then it comes back down. So using this system, you can, click wherever you want. And once you click that, you'll show what the rhythm strip was at that time. So for example, you click here, and this is the plot that you see. So there's this pause here. We can start the second half of the tracing. You see sinus P waves, maybe a PVC on the right half, but on the left half, as we learned from Dr. Qian's talk, we see this kind of irregular rhythm over here. So this is an example of, a patient who is in AFib and then converted back into sinus rhythm. So you can glean a lot of this information using the hemodynamic trends and the graphic trends. What do these patterns look like? So in patients who are in sinus rhythm, you have gradual undulation, changes in sympathetic tone. So if someone is, in sepsis and they're having cyclical fevers, temperature rises, their heart rates will go up to meet the demands of the body, right? So you'll have kind of slow, gradual changes in heart rate. Compare this to someone who has, a paced rhythm or atrial flutter with fixed block. You may have a more flat line kind of graphic trend. And as we mentioned just before, AFib, you may have more erratic RR intervals. So this is just an example of the graphic trends of someone in sinus tachycardia. So, some undulation, but not as erratic as the AFib one that we were seeing before. So you'll be handed dozens, thousands, honestly, of random strips of paper. You're going to the nurse's station. Dr. Qian, are you covering patient FJ in room 2? We got this. This is an example of, this is an AED strip. You're, working in the emergency room. A patient was defibrillated in the field. So this is, polymorphic VT, defibrillation, and back into, can't tell if it's sinus or not, but maybe can't really see the P waves. So we'll do our first polling question based on what we talked about so far. Question 2, if we could pull that up. So what is the rhythm? VT, sinus rhythm, atrial flutter, asystole. A couple more seconds. Okay, cool. So 91% of you answered VT, and some for sinus rhythm and some for atrial flutter. So I kind of set you guys up for failure by presenting that VT one before. So the first thing we'll talk about in terms of telemetry fakeouts is artifact. So here it looks like you have sinus rhythm, this P wave with a QRS. And maybe there's a QRS here. You know, everyone will think that this looks like monomorphic VT, this wide complex tachycardia going through. But if you kind of march out what this initial RR interval is and kind of put calipers, you see this little divot or change in, you know, what you think is monomorphic VT. All of these are actually the patient's intrinsic QRS. So this is actually a sinus rhythm with artifact. So you'll see this all the time on the inpatient wards. Patient can brush their teeth. They can, you know, be doing something else. Motion of the telemetry lead can look like VT if it's the right rate. So just think about it. Most of you will be starting intern year. It's better to be, you know, more conservative and kind of escalate things to your senior. You know, that's the safest thing to do for your patients. But just keep it in the back of your mind if, you know, the nurse hands this to you and you ask them what, you go see the patient and their vitals are fine. The patient doesn't even know what happened. They were doing something else. Just think about artifact. Some more telemetry strips. So for this one, we have, you know, some sinus P waves. We'll say that this is a 70-year-old man who was admitted for syncope. They're put on telemetry. Any brave souls want to come off of out of hiding and answer what they think this may be, maybe with the microphone? Okay, little bit of Zoom shyness, I get it. So we have, you know, we see these P waves kind of marching through. This is probably a PAC that's blocked, but no QRS is falling after each P wave. So kind of going back to Dr. Qian's talk, there's at least a period of AV block. We don't see any escape rhythm during this period. So we'd call this at least high grade AV block. So sorry about the sirens. So try to use all the information that you have available. You know, default settings, you may just see 2 leads when you're reviewing the telemetry. Oftentimes there's ways to add additional leads. Just click around, like view all ECG. Sometimes you can click this button and, you know, add additional leads. There's more data collected than what's just presented on the basic screen. And so sometimes certain leads look better for looking at P waves. Some leads have less artifact than others. So if you're only looking at 2 of the 6 leads, you're missing information. So just for those of you who haven't rotated in an ICU, this is just an example monitor of something you might see. So in green here, we have the telemetry, QRSs. This is your arterial line, which is an invasive type of blood pressure monitor that's inserted in commonly the radial or the femoral artery. And this is your pulse oximetry. Pay attention if you have this information available for your patients when looking at the telemetry, because it can give you a lot of information. the arterial line basically is just showing the pressure changes during systole and diastole, just continuously. So for each QRS, you have ventricular contraction, ventricular systole, blood pressure rises and then falls again during diastole. So for this strip, we have, it's kind of an interesting strip. We have this blue down here is the pulse oximeter, and we have the telemetry strip up here. Any volunteers? So one notable thing is the pulse oximeter. It marches through the telemetry. So, this was an actual case. Someone handed me a strip. I just had to blur out this thing that said the leads are off. But sometimes the machines, they'll print out things, they don't have all the labels, and you think, oh my God, the patient was asystolic for like 8 seconds or something. When if you look at the telemetry, but if it didn't identify that the leads were off, you could look at the pulse ox and say, oh, how could there be a pulse ox if the patient didn't have a pulse? So use your pulse ox if you have it available. We can open up the third polling question. So we have a 63-year-old man with heart failure with reduced ejection fraction. He's admitted for decompensated heart failure. So this top part of the strip is lead 2 of the telemetry. The second one is the arterial line, and this third one is the patient's respirometer. Okay, great. So 75% of you VT, 25% sinus rhythm with artifact. So comparing, what we looked at in the prior case, using the arterial line, right, you can see this blood pressure tracing kind of rise up, correlating to this QRS. Maybe this is like a PAC or some kind of early beat, which reflects this lower amplitude arterial line deflection, right? Because if you have a shorter interval between 2 beats, you have less time to fill the heart. So your change in arterial pressure may be less. Same thing happens here. And then all of a sudden you see this kind of wide complex tachycardia. However, on the arterial line, you see this pressure tracing just kind of fall off into the deep end, and you don't see anything, just like these little, very tiny changes in the arterial waveform. So this is ventricular tachycardia. This is not artifact. And so using the arterial line to your benefit, kind of the opposite of the last one, this is true VT. Okay. So this case, we have a 43-year-old woman with no past medical history. They're admitted for pulmonary embolism. Are we able to open the Q3 again? It's kind of the same concept. Cool, thanks. So I would say this is the respirometer. and you're called for a code blue or cardiac arrest code. And you arrive, people are already doing compressions, and the resident who's leading the code looks at you and asks, go look at the telemetry, tell me what the presenting rhythm was, because I don't know if I should give amiodarone or not if this was ventricular tachycardia. So you go to the telemetry station, and this is what you see. Great. So 90% of you show this is sinus rhythm with some artifact. So a little bit different. So, when you have patient actively coding, no one actually knows what the time of the code started. So you're going back into telemetry and you're like, was it this point or this point? And so you click at something and you say, oh, there's this Y complex thing going on here. Maybe it was VT. So should we shock the patient? Should we give amiodarone? It completely changes your ACLS algorithm. But if you look at the respirometer, this doesn't make any sense because, each, as we learned from Dr. Qian, each big box is like, if you count one big box, that's 300 beats per minute, two big box, 150 beats per minute. So that would imply that the patient's breathing at 150 times per minute, which is kind of close to what you would expect someone, to be doing chest compressions at. So at the time of the code, once you're doing chest compressions, you can see all these kinds of artifacts. And so this is actually, the patient's intrinsic rhythm, as you guys correctly identified. And all of these are actually just chest compressions. We'll do an EKG case together. So we have, starting with the rhythm from Frank's talk, always start looking for some P waves. So any kind of undulations, if you can't tell, then you'll start with the QRS complexes here. Scanning through, one tip that I recommend is look for an area of change. So right here, you kind of see there's two negative deflections in between these QRSs. It's also going at a rate of exactly 300 beats per minute. Hard to say, is this the T wave or not, or is this a P wave? But seeing something around atrial activity at around 300 beats per minute should clue you into, is this atrial flutter? So atrial flutter, for telemetry tips, it's very easy to miss 2-to-1 flutter because the F waves or the flutter waves will be buried in the QRS complexes. So one tip is to measure the P to P interval and half it and see if there's anything that resembles the flutter wave within the QRS. As I mentioned before, hemodynamic trends, it may be flat if there's fixed conduction. So take a bird's eye view of the telemetry, find irregularities to find the flutter waves. And this changes a lot. If the patient, everyone thinks, oh, they're in, sinus tach, let's treat some underlying thing. It's going to change management, right? Should you cardiovert the patient, start anticoagulation? So try to look for it. So this is the example of this kind of very flat heart rate trend over time. And you see here, there's this period, there's some change. So you're going to click into it. And this is the representative strip. And so you start to see, these two negative deflections in the inferior leads. So this patient has, typical atrial flutter. So very helpful to use the, telemetry and graphic trends. Lastly, check prior EKGs. Try to use what you know from, prior data to figure out what you don't know. Use the calipers, change the leads. There's a lot of helpful and useful information out there. So this is a patient, we have some tachycardia. We'll kind of go through this one systematically. So the rate, 1, 2, a little bit between 2 and 3 boxes. So maybe 125 beats per minute or so. It looks regular, right? Looks regular, narrow complex. I don't see any good P waves necessarily before, at least preceding any of the QRSs. Maybe something here looks a little suspicious, but can't tell if that's just the T wave. So the best thing to do is, if you have a prior tracing, pull up a prior EKG. So this is an example of the patient's sinus EKG. You see some very clear P waves, positive in lead 2, kind of biphasic, maybe a little negative in V1. So this is the patient's sinus activity. So obviously, when you compare them side by side, this bottom half is definitely sinus. This first one, if you're not sure, doesn't look like it's sinus, so something else. So this interpretation is correct, junctional tachycardia, and these are just retrograde P waves. So whenever you can't tell what the rhythm is, try to find a sinus EKG of the patient and compare the P waves. So telemetry tip summary. So what to click, hemodynamic review or graphics trends. Use this to get an overall gestalt of what's going on. Depending on how the telemetry is programmed, the alarms or events may not be too helpful. And areas of pattern change, this is where you want to focus on and just quickly click to get through your pre-rounding and see what's going on. In terms of artifact, add additional leads, use your pulse docs, use your arterial line, and check prior EKGs. Great. So thank you. This is my email if anyone has any questions. And I think we will start some EKG cases. So I will do one. Very much would appreciate if there's one brave soul willing to don't have to turn your camera on, maybe just voice, just so we can, practice interactive, working through some cases. We're not your attendings. We're not gonna email your dean of the medical school to tell you that you suck at reading EKGs. So don't worry. Here's my first case, and then I'll switch it back to Frank. A 45-year-old man with diabetes presenting with chest pain.
So I can go. The
Okay.
screen's gone. This is Meryl from the incoming PGY1 IM at Bridgeport Hospital, Yale. And nice to meet you, and thank you so much for the presentation. I think I saw ST depression in lead 1, but then the inferior leads look like a elevation. So those must be reciprocal depression in 1. So I'm looking at a right heart ST, and the screen's gone, sir.
Oh, sorry. Okay, can you see again?
Right. So, and if you want to go with more rate and rhythms and all that, but or you can take it away because I know interest of time.
Yeah, absolutely. I think thanks first for volunteering. Yeah, if you want to go, everyone obviously seeing what Meryl was saying, ST elevations. What do you think about the rate and rhythm, just to make sure we go through it systematically?
Let's see, count the boxes. Almost 7 boxes. So this is really slow. 300, 150, 110, 75, 60. Is it like 40?
Okay, yep. So 40 beats per minute. What do you think the rhythm is?
It looks, I might have to count the small boxes, but it looks regular by big box.
So we have a regular rhythm. Do you think it's sinus rhythm? Is this
sinus brady?
Sinus bradycardia. Okay. So we have sinus bradycardia with ST elevations, you were saying, in the inferior leads. and you were mentioning some depressions in 1 and AVL, maybe some depressions in V2. So per Frank's talk, what part of the heart would you say, you see elevations in 2, 3, and AVF?
Right. And if I could address the PR intervals, they do look prolonged.
Yeah, good. So now that you're kind of going back to what the rhythm is, do you want to describe, Meryl, a little bit more about the P waves and what the rhythm is?
Okay, so if I look at, probably I should look at the rhythm strip better at V1 in the middle of the screen.
Okay, yep.
The P waves seem to be independent of the QR waves, especially that second one. You can see it's jumping between the Q and the T.
Yep.
So it's really standing out that it's probably a 3rd-degree heart block.
Yeah, perfect. So initially, first glance, obviously I put this case up because everyone will see, oh my God, this is STEMI, but there's other stuff going on as well. So as you correctly said, so these are all P waves here. You can also see them on the lead 2 strip. And so what is the atrial rate, or what's the atrial rhythm? Initially, we said sinus bradycardia, but you were counting the QRS, and that was around 40 beats per minute. What about this? What is the atrial?
So Dr. Choy, I see that the P wave is happening about every 3 boxes. So with the 300 rule, so it's probably 100 per minute atrial rhythm.
Yeah. So actually this patient has sinus tachycardia with complete heart block. And so when you have complete heart block, when you go down your priority of your pacemaker cells, 1 second if I have it here. Go ahead. No. When you have complete heart block and your pacemaker cells, you have next runner-up or backups. So this is probably a junctional escape rhythm, right? Somewhere around the AV node or AV junction. And so sinus tachycardia with complete heart block with a junctional escape with ST elevations in 2, 3, and AVF representing an inferior STEMI. These are, as you said, reciprocal changes in 1 and AVL. Great job.
Thank you.
Frank, if you want to take over.
Yeah, happy to. Let me share my screen. All right. So my first case is actually pretty similar to what Alex said. So I'll do a subsequent case. All right. Can everyone see my screen okay? And I guess just like last time, I would appreciate if anyone would bravely volunteer, just kind of go by, what I was discussing systematically, take us through what you think the rhythm is. I think someone's typing in the chat. So Anik said there's ST depression. Yeah. Where would you say that's occurring? Okay, yeah, so you say there's ST depressions lead 1 and 2. So in a way that's correct, but there's another very kind of unique finding to this EKG that if you recall, I was kind of discussing earlier. So LVH, yeah, I think that if you look at it, it's probably present. I don't know if it quite fits the criteria, and actually I don't think it does. But you certainly have these very tall R waves. Exactly. Yeah. So you point, Iris, you're very right. So the PR interval is clearly shortened, but I would actually argue they are correlated. So you can see that, you know, this P wave correlates with this QRS, this P wave correlates with this QRS. What, if you recall, what can sometimes cause a shortened PR segment?
Delta wave. Slur.
Exactly. Yeah. Exactly. So you can see this. This is a very kind of classic, what we call pre-excited EKG, where, you know, you have this shortened PR segment, and then this sort of, you know, it's not a very sort of smooth R wave. It's sort of very slurred out. And then going back to what Anik was saying, you'll oftentimes see in this situation kind of like a downward PR depression with almost like a T wave inversion. But this is, you know, a pretty classic EKG for, you know, pre-excitation or Wolff-Parkinson-White. So very good. You know, and this, you know, rhythm, I would say underlying rhythm is sinus. You can see, you know, sort of, you know, upright P waves in the inferior leads. And there's kind of one-to-one conduction going on. Okay. So we'll move on to the next one. What did people think about this EKG? I guess, you know, just to kind of go through it systematically, you know, what's the rate, the rhythm, the axis, all of that. Yeah, Meryl, can you clarify what you mean by check the leads?
Sure. It just almost feels like it's upside down altogether. So I don't know if one or two of the leads might be switched, but I have to look closer.
Okay. Yeah, I can tell you this is, you know, the lead placement was fine.
Okay, perfect. Mhm. They look kind of low amplitude. Okay, so rate
Okay.
rhythm.
Yeah, I agree. Yep.
Okay.
Yeah, go ahead.
All right, so P waves, 1, 2, 3, 4, almost 5 boxes, then 4 boxes. Where's my rhythm strip? Down here.
Yep, this is lead 2 rhythm stroke down here.
Yes, every 5. Thank you. See, I see it. R to R is 1, 2, 3, 4, 5, and then 1, 2, 3, 4.5, and then 1, 2, 3, 4.5, and then 5. So it's kind of irregular. But about 300, 150, 100, maybe 75, 60 beats per minute.
Mm-hmm. Yeah, and I agree with you. You know, it does look. It's probably mostly irregular. There's, you know, down here it looks like there's a little bit of irregularity, but these are probably, you know, what we call PACs, or premature atrial complexes, and then other, you know, R to R intervals are pretty consistent. So
Why are
I think
all my T values upside down? Go ahead.
yeah, very good. So, you know, I think someone was pointing out a lot of the T waves look inverted, and that's exactly right. So you can see these, you know, normally the T waves should kind of be upright. like this, V1. Actually, V1 should be inverted, but you can see these very deep kind of T wave inversions. And one other thing to note about these T waves is that they're symmetric but very deep. And so this is actually a specific pattern called cerebral T waves. Most of you might not have seen this before. This is a sign of increased intracranial pressure, and oftentimes this will be associated with very kind of these very deep T wave inversions. The other way we know this is probably not ischemia is look how diffuse the T wave inversions are. You sort of see them throughout the precordial leads as well as in the inferior leads. You wouldn't generally see this with kind of localized ischemia where you might have just sort of T wave inversions in one kind of coronary territory. And I think Marshad, you mentioned patient had an ischemic stroke. Yeah, I think that's possible. They might have had an ischemic stroke, and they might have had a hemorrhagic conversion and thereby have this kind of increased intracranial pressure. So there's your one EKG, particularly for those who might be going to neurology or neurosurgery. If you see this pattern, this is a sign that the patient probably has increased intracranial pressure. All right. So I can do one more. All right, so again, let's go through this EKG systematically, although it's admittedly quite ugly.
Looks like VTAC, and it's irregularly irregular, so maybe AFib degenerated into VFib, not VFib, just rapid ventricular response. Your beats are like,
so that's
someone's
actually
talking.
exactly right. So you're right, it is AFib, because of how irregular it is, but you recall that AFib is a supraventricular rhythm. So why would it be wide? First of all, if you recall from when we discussed why a QRS complex might be widened, this is one of those situations. Yeah, Rashad, that's exactly right. Yep, and then you got it too. So this is a very kind of classic EKG pattern that is important to be able to recognize. So, first of all, I think everyone recognizes this was irregular, and, importantly, I'll point out it's irregularly irregular. So, there's, you can see that, maybe here there's kind of a pattern to it, but I think for the most part, the R to R intervals are varying quite a bit over time. Like here, it's closer to 300, whereas here it's probably closer to 130 or 125. The other thing to note, you could explain why this is wide is, you may recall that when you have a wide complex tachycardia, the differential is, ventricular tachycardia or supraventricular tachycardia with aberrancy. And in particular, you can oftentimes get aberrant conduction with, either some kind of bundle branch block, or in this case, I didn't give you this patient's, kind of baseline EKG, but you can kind of see in some of these complexes, there's kind of this slurred upstroking R wave. And again, that was part of the reason I showed you that earlier EKG was I wanted you to be able to recognize that this is a sign of pre-excitation. Now, technically speaking, you can identify pre-excitation without looking at a baseline EKG, but just for the sake of going through interesting cases, this is a EKG that has baseline pre-excitation. And other ways you can also tell this is probably not ventricular tachycardia is looking at the axis. So it has a completely normal axis. Not to say that ventricular tachycardia can't have this, but this is one other reason you might say ventricular tachycardia might be a little less likely. And so you see like up in 1, up in ABF, up in 2, so completely normal axis. And one other thing I'll point out that's kind of interesting is if you look at the lead 2 rhythm strip, you have this sort of undulation in the QRS height. Do people know what the term for this pattern is called? So where you see kind of a variation in the QRS height. So Ashton, not quite. So again, we identified this rhythm as AFib, so this is not torsades. But yeah, William, you're exactly right. So this is something called electrical alternance, or sometimes called QRS alternance. And you might have often heard that term, kind of affiliated with something called cardiac tamponade. And in that situation, it's sort of related to the changes in electrical activity because you have essentially a big fluid pocket around the heart, and that, depending on how the heart is contracting inside that fluid, it can change the QRS, height. But you can actually get this with most types of supraventricular tachycardia because of how quickly the conduction is going through. You will sometimes see this, pattern. So, you should always think about whether this could be affiliated with, sort of a pericardial effusion, especially if the patient is otherwise, has a normal rhythm. But in situations where they have supraventricular tachycardia, this is another situation you can see that kind of electrical alternance. So great. I think that's all the cases I had.